Hi, I'm Sunil Reddy, and I'm going to talk to you all about your upcoming hip replacement surgery. Before we delve into what happens in the operation theater, let's talk about what are the components of a hip replacement. So the hip is a ball and socket joint, and when you wear out the cartilage in the socket and the ball, that's when we need to do a hip replacement surgery. The hip replacement has three parts. One is the metal socket. As you can see, the metal socket has a rough metal surface and bone grows onto it, and that's how it gets its fixation. The second part is what we call the stem. The stem too has a rough surface and a special coating that allows for bone to grow onto it. And the third part is the socket. The socket is made of plastic, and as I can show here, there is a ball, and the ball and socket form the joint. The thigh bone, just like other large bones in the body, is a hollow tube, and we prepare a precise wedge in the thigh bone into which the stem goes in to get its fixation. So now if we go into what happens in the operating theater. For the hip replacement surgery, we give an incision on the outer side of your hip or in the front of your hip. Because in terms of the hip replacements, this can be performed through a posterior approach or an anterior approach. Many of the times, hip replacement surgery is performed under what is called a spinal anesthetic. A spinal anesthetic is where the anesthetist gives you an injection in the back to numb you from waist down. And this is our preferred means of anesthesia, as it is quite safe and also allows for prolonged pain control for 12 to 24 hours. The anesthetists also sometimes use what is called a nerve block. This means that your leg may be numb for quite a few hours after the operation. There is nothing to worry about and is usual. Once the incision is done, we seed the implants. As I said, they are intended in such a way that bone can grow onto the prosthesis. But sometimes the parts may need to be cemented in place using a bone cement, especially in the very elderly people when the bones may be weak or the tube inside your thigh bone can be quite large. Once the surgery is completed, the wound is closed and you would go to the recovery. Typically in the recovery, you would spend about 1 to 1.5 hours, after which you would go to the ward. And once you go to the ward, I strongly encourage that you try and stand up and at least sit out in a chair the same day evening after surgery or the next day morning. Our physiotherapists will help you do that, and so will our nursing staff. Once you gain control of your leg and you can feel your leg well, then you would be able to stand up, walk, and you will need to use walker initially or crutches depending on your preference and what the physiotherapist recommends. After the initial days or weeks of using a walker, you can then transition to a walking stick and then eventually will be able to walk without any aids. And this process can take anywhere between 2 weeks to 4 to 6 weeks. Typically, for most patients, you would stay in the hospital for between 2 to 3 days. But it is not the number of days that matters, it's rather how your recovery process goes, how soon you are able to get in and out of the bed, go to the shower, and take a walk in the lobby. As soon as you achieve these objectives and the nursing staff and physiotherapist feel it is safe for you to go home and you feel confident to do so, you can go home. My preference is for you to recover at home rather than in the hospital. The longer you stay in the hospital, the more that we have observed that you could catch bugs and infections that are prevalent in the hospital environment. Once you are discharged home, you would have physiotherapy appointments organized by our team. The physiotherapist would initially see you on a weekly basis and help you through your exercises. But it is critical that you perform the exercises at least 3 times a day, 20 to 30 minutes each time. In view of your recovery and rehabilitation process, the earlier you start walking, the more you exercise, the better is for your hip in terms of the movement as well as the strength that you gain over time. It also helps decrease the risk of infection in your chest, infection in your urine, blood clots in your legs. Now, I would like to talk to you about what you can expect from your hip replacement. What are the benefits that you can expect to achieve? And also touch on what are the risks and complications associated with this procedure. Total hip replacement surgery is one of the most successful operations in the medical field. About 95% of people who have the surgery can expect to have a pain-free hip on which you are able to walk long distances. You can bike, you can swim, you can play golf or any other non-contact sport. Of course, it is going to take time for you to heal from the surgery, to improve in terms of the pain, the swelling and mobility, and you can expect to obtain a lot of improvement at about the 2 to 3 month mark. But by 6 months, most of the recovery would have occurred, but it will continue till 1 year. And at 2 years, you will be better off than what you were at the 1 year mark. You would notice that we ask for some information about your hip, about your pain, your activity levels, your sleep, and various other aspects before the surgery and again periodically after surgery. So these help us to objectively estimate how well you're doing in terms of your hip through certain scores. Now, I would like to talk about the risks associated with the operation. Every surgery that we do is a trade-off between benefits and risks, and we do the surgery because the benefits far outweigh the risks. We take a lot of precautions to keep the risks and complications to a minimum, but it is never down to zero. So the first thing is infection. So infection is a big deal in joint replacement surgery. And in spite of all of our efforts, about 1 to 2% of hip replacements can get infected. And this infection rate increases to 3 to 4% if you have diabetes. If you do get an infection, we will need to do more operations to clean it out and give you antibiotics through your IV line for prolonged periods of time. In the worst case scenario, we may have to remove all the old components and place something called a spacer and a bone cement that is loaded with antibiotics. Then we'll give you antibiotics through your veins, and once the infection is controlled, maybe in 2 to 3 months, come back and then put in new components again. So as you can understand, it is a big deal, and we make a lot of efforts to minimize this risk. And from your part, you can do quite a few things to minimize this risk. If you have diabetes, please make sure that your sugars are well controlled. If you smoke heavily, make all efforts to cut down or quit smoking in the period before, during, and after surgery. And if there is any problem in terms of the wound early on, please come and see me or our team as soon as possible. The second aspect of recovery following a hip replacement or a knee replacement that we take very seriously is blood clots. These clots themselves are not often so dangerous, but they can break up and occasionally clog up our heart and lungs, and rarely they are life-threatening. The best means to avoid these or prevent these clots as much as possible is to get up and about, start moving your ankles, your knees, and walk around straight away from day one. We also give you TED stockings. These are these white stockings that you keep on all the time, if possible, for the initial 3 to 4 weeks. We will also give you blood thinners. The commonest the drug we use is aspirin, but if your risk is high, then we may have to give you injections. The next risk that I would like to talk to you about is hip dislocation. Any hip replacement, as we spoke about, it is a ball and a socket, and in certain positions about 1 to 2% of hips can dislocate. Any hip can dislocate if taken into an extreme of position, and our physiotherapists and myself, we will talk to you about what are the safe positions for hip. So one example is when the initial 3 to 4 months after surgery, when you get up from a chair or sit in a low chair, if you take your legs to this position to stand up, that's a position that the hip does not like. The second is twisting movements is something that you need to avoid. Apart from this, all other exercises, walking, biking, all of these things can progress over time. We take, again, a lot of precautions to avoid hip dislocation. And by the time I complete the surgery, I make sure that a hip is as stable as possible. But in about 1% of patients, as I said, it could happen. If it does happen, it can be put back in place either in the operation theater or in the emergency room. That is not so much of a problem. The problem is, once it pops out, it can keep popping out again and again. And if that happens, we will need to do an operation. When we do the hip replacement surgery, I make all-out efforts to keep both your legs as perfectly of the same length as possible. And we have special instruments that enable us to do so. And we are able to measure it on the operating table. But there are certain situations where during the surgery, I have to make a decision whether it is the length of your legs or the inability of your hip to pop out that is more important. Because some of the steps that we need to make during surgery to stop your hip from popping out have the side effect of slightly lengthening your leg. This could only be a few millimeters. And if this happens, which is very occasional and uncommon, you may feel initially that one leg is a little bit off compared to the other. Again, that is not so much to worry about because most of the people by about 3 to 6 months don't feel it as much. In the worst case scenario, you may need to have a shoe rise on your other leg or the normal leg. Other complications of a hip replacement, including anesthetic complications like you can get heart attacks, you can get a stroke, you can have fracture of the bones while we are doing the surgery, and all of these risks, the percentage is never down to 0, but they are very uncommon. And again, you can be reassured that me and our team take a lot of precautions at every stage of your surgery and recovery to give you the best possible outcome and minimize those risks. But they can happen, and if they do, then we will have to deal with it. Lastly, whenever we place an artificial component into your body, it is always a race between whether the parts outlast you or you outlast the parts. Our objective is for the hip replacement to last forever, and most of them do. We know that about 90% of hip replacement components last at least for 15 to 20 years.